record so I don't forget. Okay. All right, so we left off on acids and bases is right here. Okay. All right, so we talked about yesterday the importance of remembering the numbers, right? Okay, let's see. So we said, just a really quick review for those who are in here. First, we have to consider the numbers for the pH, and it tells us whether it's acidic or basic. We know if pH is low, that means that the body is acidic. That's what pH means. If pH is high, that means the body is basic. That's what pH means. Then we consider the two different elements that can make the body either acidic or basic. The first one is carbon dioxide, which is an acid. So it makes sense that if carbon dioxide, which is an acid, is high, it's going to make the body acidic. And if carbon dioxide, which is an acid, is low, it's going to make the body basic because the body has both acid and bases in it, both carbon dioxide and bicarbonate in it. So when the acid goes up or down, the bicarbonate stays the same, right? So when the acid is getting depleted, getting removed, the base is still here. It's not getting removed. So that's why when we get rid of the carbon dioxide and it's low, the body's basic. And then we think about bicarbonate, which we said is a base. So if bicarbonate, which is a base, is high, it makes the body basic. If bicarbonate, which is a base, is low, that means there's still carbon dioxide in the body and it's still at a regular level. So when the base goes down, the acid is still there, the body is acidic. Then we said, when we're thinking about it, wait, what was the third thing we said? I forgot. So then once so we considered the pH, we considered the carbon dioxide and the bicarbonate. Then we consider which we have to remember carbon dioxide has to do with the lungs, so it's a respiratory thing, and metabolism has to do with the kidney, so it's a metabolic thing. So then we got to identify what is causing the problem. And in class I didn't mention it yesterday, but we call the problem by its name, and this is where we kind of left off. So we think if the problem is a respiratory issue, carbon dioxide, then we're going to call it that. We're going to say it is the lungs, the carbon dioxide, the respiratory that is causing the acidosis, and that's why we call it respiratory acidosis. And if it's the lungs that's causing the base because it's getting rid of too much of the acid, we're calling it respiratory alkalosis. And then we said, if it's the kidney or the body, metabolism, not body, but metabolism, it could be the stomach, it could be whatever it is, then it's going to cause either metabolic acidosis or metabolic alkalosis, okay? So that's where we kind of left off, and I mentioned that part. So now for your exam, and just for your understanding, we want to understand why the respiratory might have a problem. And we have to remember that there's a difference between when it has a problem and when it's trying to fix a problem, right? So we have to know if it's respiratory acidosis, what are we going to see, right? We're going to see first things that are problematic, like, hold on, let me get to it really quickly. No, we're going to look at the things that caused it. That's the problem, and then we're going to see what the body is doing in order to compensate for it, and that's what we were talking about yesterday. So we're going to see what caused it, trapping, right? Because it's an obstructive problem. So the asthma is how we kind of figured, okay, asthma, there's vasospasm, there's swelling, and it's not allowing the passage of the air. There's a lot of thick mucus. So that's an obstructive. So it's not letting the carbon dioxide out. So we said asthma was a problem. And we said the asthmaticus was our example. that's definitely going to cause respiratory acidosis because it's a prolonged trapping. Same thing with COPD, which is another obstructive issue, right? And so its problem with COPD, when we think of emphysema and bronchitis, we'll get there. We think about, well, the person breathes in okay, but either there's the muscles of the alveoli are too lax, so they can't get rid of it, right? We say it's now a paper bag. It's not like that elastic balloon. So the carbon dioxide stays inside. So either the passageway is closed, in asthma, it's closed, or passageway is open, but there's no action to send it back out, right? So those are the reasons why we get respiratory acidosis, and it is respiratory because this is lung.
But I looked at like stuff that we learned though,
Mhm.
and also online.
Mhm.
It said that asthma is alkalosis. The status is acidosis.
It says for asthma, it's alkalosis.
Yeah.
Hold on, let me check that really quickly.
It just depends, like if you're having asthma attacks, you know what I'm saying? Compared to
Right.
this
So
asthma.
that's what we were saying. And that's what you're right, Michael. We said yesterday that it's the asthmaticus that caused the respiratory acidosis because it was trapped for a long period of time. And then we said the shallowness was, and I think that's where the confusion was truly. So go ahead, Michael, say what you're going to say one more time.
Like, so when you have like the asthmaticus,
Mhm.
you're like barely breathing and stuff like that, compared to asthma, like it's just like the development of like what's going on. Cause like if it's hard to explain. I just know that.
So with, and that's what we were trying to say yesterday. We were saying that with the hyperventilation, it was shallow, but we were still getting out the carbon dioxide. So I was saying that you're not getting out the carbon dioxide, but you are. And that's why the asthma, but the asthmaticus, it's not coming out. That's what it was. That's what it was. Right. So the asthma attack, the hyperventilation, even though it's shallow, it's still coming out. Whereas the asthmaticus, when you're breathing fast, is not coming out because it's trapped.
Okay.
That's what it is. Makes sense.
We all talked about it after. Maybe
Okay.
like shooting, we're like.
Yeah. Okay. It makes sense. It makes more sense that way. Okay. So the asthmaticus, okay, so we got that. So respiratory alkalosis, we said. So then there's the asthma with the hyperventilation, hypoventilation, hyperventilation. So increased rate, increased depth. So then we have tachycardia, we have normal blood pressure or decreased blood pressure. So then we have it's cardiac deficit, carbonic acid deficit. That's where we get the pH that's greater, right? All of that. So things to remember is, again, what is causing it, and then the effect of what the person is going to do in order when they do have it, right? So what causes it, right? Whatever caused it is going to define what it is. And then whatever reaction that the person has because of whatever they're feeling is also going to define what it is, right? Okay, so when we get to metabolic alkalosis, then we kind of get to the metabolism where we're thinking about, acid in the stomach. We're thinking about when the person has diarrhea, what happens, right? So we said acid is hydrochloric acid. So hydrochloric acid is when you vomit, you're releasing an acid. So that means you're causing the body to be more basic, right? Whereas if you have diarrhea, it's bases that you're releasing. And so then whatever's left behind is more acidic, right? So depending on where either the suction or the vomiting or whatever it is, where it's coming from is what's going to define what the person is going to be like. We mentioned that all of them are important for you to remember, whether it's respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. We said metabolic acidosis was the one we see most often because that's the one that has the ketones with diabetes, with the Kussmaul's respirations. And this is, so the crucial respirations, and this is why I got it confused with the asthma, is this is happening because of the acidosis, right? And so when you see it, you're thinking, oh, they're breathing fast, so there'll be alkalosis, but they're trying to get rid of the acid, okay? So that's that there. What else? Moving on. Okay, so we talked about, like in the class, like how to decide the numbers, how to answer it. And that's really important because you want to make sure you know what the numbers mean, but you also want to know, what causes it, what the treatments are, and it's always going to be according to what the problem is, right? Let's see. We also want to know ABGs. What do they do them for? Obviously, they want to check the, pH and arterial gases kind of thing, right? That's what they're there for. Does anyone want to go over the numbers again, like how to decide what is acidosis, alkalosis, or should I just continue and then get back to that if we get a chance? Yep. Okay. Right. So,
It's
and
usually opposite for that one. Like when you write it, to like make it easier. for you,
Mhm,
just do
mhm.
45
Just
percent.
drop the
Yeah.
7.
Yeah, sure. I always drop the 7 too. So, but we're good with, if they give us those numbers, identifying which is which. Good. All right. So let's move on. So then that was acid bases.
Next is pneumonia.
Thank you. Let's get to pneumonia. Okay. So with pneumonia, so again, like, remember, this was like kind of your worst exam. And again, it was because of the fact that they were so similar. And I try to emphasize on the differences. So let's go over those differences one more time. Okay. So, so we're looking at, when we look at pneumonia, what are we looking at? What is the problem with pneumonia? What caused it?
Liquid.
It's liquid, that it's a bacterial thing. It's an infection, right? The others are not infection, right? The others, there are other issues. So pneumonia is an infection issue. So we're going to listen. It's also a fluid problem too, that's trapped, and it's a fluid that harbored the bacteria. So we're going to look at crackles. We're going to look at white blood cell count. It's nice to know where things are, but it's not the priority. We just really want to know how to identify it, right? Like if it's a different color, we know it might be a different kind of pneumonia, right? Whereas the others, they didn't tell us about color of sputum, right? There might be blood in this one, and that matters. The others didn't mention about blood as much, right? Maybe COPD emphysema a little bit, but not really as much as pneumonia. That would tell us, like, if it's brown, or if it's green, or if it's bloody, right? So we got to remember that. That's a difference in them. Chest x-ray, right? That's something a little different from the others too. The chest x-ray that we do for the others does not tell us anything about the disease per se, but in pneumonia, the chest x-ray does tell us where the fluid is sitting and if there is pneumonia at all, right? So that's an important thing to remember. Also, because it's pneumonia, because it's an infection, then we need culture. We don't need culture for the other ones because there's no infection there. So again, we're looking at the differences, but let's think about the similarities, because that's also what trips you guys up when you're seeing multiple questions where all of the answers are check the pulse ox. Yes, they're all going to be check the pulse ox. Pulse ox has to be greater than 95, right? Or greater than 90. Or another question was like, how do you know it's improved? But they didn't give you numbers before. You want to know that it's getting greater than 90, right? Greater than 95, right? We talked about yesterday that we don't want to look at a person and say, oh, he looks good. We don't know what's happening on the inside. So we want to see measurement. So always try to pick the one with the numbers. But if you're comparing numbers and there's a number that talks about the breaths per minute, right? We don't want to pick breaths per minute over oximetry and saturation, because breath per minute doesn't tell us how the blood is running to the tip of the fingers and saturating and perfusing the body, right? But oximetry does. And so we want to pick the better answers, and that's how we do that. Let's see, common diagnosis. assessment. So we're looking at the vitals, important, SaO2 above, I don't know who that is, above, what is it called? Oh, so, and then we have saturation, and that's the other thing too, because sometimes the questions talk about partial pressure and saturation. So the question is mostly on saturation. So, but if the number hits 85, to me, that's just bad, right? Whether that's oximetry or saturation, that's just bad, right? So we want to hit as high as 90 in both of them. So even if you see a number that's 88 and you're like, is it partial pressure or is it saturation? I'm not sure. If it's in the 80s, it can't be good. And that's like a general rule until you remember that saturation is 95 and above, or greater than 90. And
Unless it's COPD.
unless it's, see, and I say greater than 90 because even COPD has to be greater than 90.
Like 92.
Anyone who's not COPD can be 95 and above. If they hit 95, they're going to feel some type of way. But COPD, if they hit 95, they hit 90, they're fine. But once they hit 90, they start feeling a little weird. So that's why I say 90, right? And so if it's COPD, greater than 90, but if it's a normal person, greater than 95. So that's that. Let's see, anything else? Chest pain. So they have chest tightness too. They have chest pain too. They have production of sputum too, because coughing, if you're emphysema and you're a smoker, you're gonna have coughing. What else they have, right? Yeah, that's about it. But we want to focus on the things I mentioned. Chills, right? That's a fever thing, right? Fever, the number, that's a pneumonia thing. So we want to look at the things that make them different. So that is pneumonia. What's the next one? Asthma. Okay, hold on. Let's see. Let's go. Here we go. Okay. So with asthma, we said we want to look at the differences, right? The biggest problem, first of all, we want to know what's happening, right? Asthma is the vasoconstriction, it's the swelling because of the edema, and it's the mucus production that's causing this tightness. And the tightness is localized in the trachea, right? So that's an important concept to remember. And what are we going to see? The biggest thing is we're going to hear wheezes. Like we will hear wheezes in pneumonia too, if there's trapping but not as much, right? It's mostly with pneumonia, it's crackles, right? We might, but it's mostly crackles. But with asthma, we'll hear wheezing, right? So that's a difference there. We're gonna have the breathlessness, the chest tightness or chest pain, we're gonna see it here too. We're gonna have coughing here as well, right? But we wanna pinpoint the wheezing, absent or not. If it's absent, we have to make sure that the person is oxygenated for us to know if it's healed, right? So we want to see that. The sensitivity is the biggest thing, right? The reason why this person has all this mucus production and swelling and vasoconstriction is because there's a trigger that they're allergic to. The body sees it and says, that's a foreign object. I don't like it. I'm going to go kill it. I'm going to go fight it to get rid of it. But then the body's immune system reacts that way to a bacteria, but it doesn't know what to do when it finds a foreign air, like a pollutant, pollution, or a chemical. It doesn't know what to do. So when it gets there, it can't destroy it like it destroys the bacteria. So it just keeps bringing in reinforcement. Eventually it swells up the whole thing and then it shuts it down. So the problem is sensitivity. That makes it super different from all the others, right? And we mentioned there are different kinds. There's exercise, there's dust mites, there's scents, there are chemicals, there's cold, right? There's different ones. And once you now find it, the biggest thing in order to prevent it is eliminating the trigger, right? Not pacifying it, getting rid of it. First, you want to help them identify what it is. And then once you do, you want to get rid of it. So if it's a carpet, out of there. If it's,
That was your exam question.
huh?
That was your exam question.
Must be. I remember that. Yeah. Yeah, so definitely you have the carpet one or whatever it is. Like you want to get rid of the thing. You want to, what else? Like, you know, can I,
Like not dust the plant.
not dust the plant because the plant is still there, right? It's
That's what
still
I'm saying.
there. It'll still accumulate it. If the plant is attracting dust, remove it, right? Get the, no dogs. Yeah, get rid of the dog. What else? You know, don't go out when they're doing, or I don't know.
Change the floor to top. That was the answer.
There you go, right? You just you're removing the trigger. You're identifying it and removing it. So that's how we treat it. Think about risk factors, right? We talked about like family history, smoking exposure, environmental exposure. That's good to know stuff, right? Weeds, dust, moles, animal dander. These are some of the things that we talked about. We talked about some of the things. There's emotional too and stress as well. So we're getting rid of the stress, right? We're getting rid as much as we can with those things, but it's a sensitivity situation. Then we talked about the spacers, and we said, how do we know the person is doing okay? They have to be in green, right? Well, spacers are when you're taking the medication, right? Forget that. So we're talking about the incentive spirometer. Nope, that's still the same thing. Peak flow meter, there you go. Incentive spirometer is to help us expand the lungs and whatever, right? So the peak flow meter is to help identify where the person is on the medication that they're taking. So if we're in the yellow, we're good. In the green, we're good. If we're in the yellow, nah, we might need to go to see the doctor to ask them, can we change the medication? If we're in the red, within 24 hours, the person has to go get help because something's going to happen. They might get an attack. They're not breathing at the capacity that they should breathe that maintains life, right? So what are the things that we're going to see? Like, again, when you're studying, please don't focus on, tachypnea, tachycardia, because you're going to see that possibly in all of them, right? You want to focus on the wheezing. You want to focus on, increased mucus production, vasospasm of the bronchioles. Like you want to choose the ones that specifically for that one, and just like, okay, all the others, the others have that too, right? Let's see. Impending respiratory failure, right? It could shut down and no breath. Whereas the others, it's not the failure that's going to kill them, right? Well, pneumonia, yes, but the COPD and the other one, it's more at this acidosis that's going to kill them, right? But not getting oxygen is a problem too. So, that's with all of them, to be honest. Diagnostics, we talked about the peak flow meter. That to me is the most important. But knowing about the spirometer, knowing how to, show them to cough and to deep breathe and to change position and all of that, telling them, we also remembered about the eating and the breathing. They can't do it at the same time, it seems. So we don't want to ask them all these questions. So we want to kind of, give them time, to rest, right? And not bombard them with all these questions if they're not breathing properly. What else? Activity, the same thing. So breathing, eating, activity, we don't want to do it too much because that as they're doing those things, they're not breathing properly. Thoughts is about it for that. Let's see what else. Medication is important. Yeah, so look at the medication list, right? First of all, the most important thing we know is what? Beta adrenergic, but more so, no, the albuterol. The albuterol is the most important. We want to make sure you definitely want to give them that, because what does that do? Vasodilates. It pops it open so that they can get the oxygen right away. And that's a rescue medication, right? Then the other one is the corticosteroids. All the others are corticosteroids. So the albuterol is a really only one that's like that active right now rescue, and everything else is maintenance. Yeah, that's asthma attack. So you don't want to give all the others if they're having an attack. So identifying the others is important too. Like, what exactly do they do? Try to remember that, right? Knowing fast acting versus long acting, and knowing the different names. Like, try to remember, like visualize the names, and so that if they say them, you'll remember, right? If they mention it, because some of them are key. And I use the ones that I've seen used most often on exams. and on NCLEX and whatever. So at a glance, if you have a good memory, you'll remember. As long as you remember albuterol is the one that you give for active, right now, rescue, you know anything else you see, if they're telling you the person's having an attack, you're not giving it. So if the word it doesn't say albuterol, you're not giving it, right? So that's if you can't remember the others, that's what I'm saying, right? So that's the most important thing. And that's about it really. But again, so the thing as you're studying, right, and this is for now in the NCLEX, you want to remember things that you're never going to forget first and engrave that in your mind. And then you want to add to it a little bit by little bit. So like right now, the key thing is remember albuterol is rescue and all the others are corticosteroids or are not rescue. Then you want to say, once you got albuterol in your head, and anytime if somebody asks you, you could come up with it quick. Now you want to be like, okay, now let me try to remember some of these corticosteroids, and then remember them one at a time, right? Like when you first look at it, you think of somedrol, whatever, right? First you think of that. Okay, so albuterol is the thing, and somedrol is the corticosteroid. Okay, and then you will study something else, and then okay, albuterol, somedrol, and then the other one is like theophylline. Okay, somedrol and theophylline, right? Like you kind of build up on it so that you can kind of remember them. And that's how you study, because you want to at least know some things for sure. And then the other things that you add later on, if you forget them, at least the one that you know for sure will still save you, right? So that's how you want to study. So that was asthma. What's the next one?
COPD.
COPD. Okay. So with COPD, right, we want to know there's a problem there. There's two different ones that we look at. We look at the chronic bronchitis and the chronic emphysema. They are so similar, but we still want to identify the things that make them different, right? So the things that make them different with the chronic bronchitis, it's about, the key thing was if they're coughing for over like 3 months, that means they have bronchitis, right? That's the biggest thing. There's inflammation, there's a problem there. Then there's a blue bloater thing. So that's something that makes them different as well. And then it also has to do with the mucus plug, right? So mucus, the cough. Oh, my dad, sorry. Let me call him. Let me call him back. Allô, papi? Bien, oui. T'aimerais le bac, non classe, okay? Okay, bye-bye. So yeah, so we have the blue bloater, right? So blue bloater, we want to remember. What's the next thing we want to remember? The amount of months that would tell us that it's chronic, right? The amount of mucus that's there. So the mucus is like, it traps it in there as well, right? So we have, let's see, anything else? Hypoxia, we know hypercapnia, we know respiratory acidosis. That's a key thing too we want to remember. And there's smokers, right? It happens to smokers. So those are the key things we want to remember. You know, obviously, like I said, you want to remember those things first, and then you want to expand and try to fit more things into your memory. And then as you think about it too, you want to see like and this is where the reading comes in. As you're remembering those things, don't just remember words, but remember expressions like, you know, why are they a blue bloater, right? Why is there production of a lot of mucus? And that way it'll be imprinted. It's not just a word or a term, but it's a whole experience with the information that's going to stay within your mind. Right. So we have the exertional, orthopnea. Orthopnea is another thing too, right? As they change position, they can't catch their breath, right? So that's a little different than we've seen. As we study, we want to catch the differences. So now emphysema, we look at the lungs more so. The bronchitis, we see bronchitis, it's the bronchioles, right? Whereas the emphysema, it's more of the sacs, the alveoli. And so, but both of them, including the bronchitis, the biggest thing why we see a change in the person's posture there's trapping, right? It's stuck. That's why there's respiratory acidosis. So we want to realize that these people are going to try to like accommodate themselves so that they can breathe better. So the emphysema, though, we see the barrel chest, right? We see they're a pink puffer, right? We see speak in short, jerky sentences. We didn't see that in the other one as much. We see the wasting away. That's a little different. They're really skinny here. So we want to, again, identify the small issues. Now, let's talk about a little bit what's in common that you definitely have to remember for both of them. If there's carbon dioxide that's stuck inside, if there's trapping, we want to get rid of the oxygen, of the carbon dioxide. And the best way to do it is with pursed breathing. So identifying that, that's a key thing you have to remember. What is it for? It's in order to give them control so that they can whatever that word is, bring out the carbon dioxide that's stuck inside, okay? Also with emphysema, we also have the possibility for heart failure, right? And we talked about, pulmonary hypertension, right? And we said like the arteries, if they're not working properly, they shunt their blood to another area, and then that builds pressure and builds pressure. But then the heart is like right next to the lung. So when that pressure is building, it's a lot of tension and it causes an issue, right? So that's another thing that we see here that we didn't see in the other one as much.
Wouldn't that be bronchitis though?
It's in both. So we have heart failure, and we have right-sided heart failure in emphysema, and we have what is it called? Right-sided failure in bronchitis as well. So we have the increased jugular vein distension for bronchitis. So we have heart failure in both of them.
Sorry, you said pulmonary hypertension.
Hypertension, yeah.
Is it increased jugular vein distension in emphysema as well?
I have to think about that.
What was the question?
Is there increased jugular vein distension? I would have to look that up.
That's for bronchitis.
But it is because there's heart failure. Whenever there's heart failure, there's a lot of accumulation of blood, right? So if we have right-sided, so left-sided is lung issue, right-sided is body issue, right? It backs up to the rest of the body. Let's see, what else? Right side heart failure, cor pulmonale is part of that. Okay, all right. So just remember the heart failure, right? That happens with it. Then we want to look at complications. We always want to remember complication. Remember I mentioned that? Always want to remember complication because that's what we were trying to prevent. So definitely remembering that it can cause heart disease, right? Remembering that pneumothorax, which is when the little blebs burst in the alveoli and causes a collapse in that area. And so now that area is not being used. And so now there's less places for perfusion and it becomes a problem. Risk for pneumonia, because if it's not being used and there's possible, like if you don't use it, you lose it, and there's possibly swelling, which we know is part of the whole thing. And then that means fluid can move from one place to another, and then that can cause pneumonia. Lung cancer, that makes sense because if there's deterioration and there's breakdown and there's problem, then there's also healing. And if there's healing and it's happening too often, then it can proliferate and start causing cancer, right? FPTs, just knowing the idea behind it. Not FPTs, PFTs, pulmonary function test. You have the spirometry, the tidal wave minute, like you just know the concepts behind it and why it's being used. If you see it mentioned, you know it's a lung issue, right? Now, for medications, we're looking at
Antibiotics.
Antibiotics for sure, yeah. If it's needed, we're definitely going to use antibiotics prophylactically sometimes. But the most important ones are like not bronchodilators, but anticholinergics, so that because they have a lot of mucus production, so we want to kind of dry things up so that it's not hurting them to cough. We want to do corticosteroids for the inflammation that might happen, right? So remembering which ones, remember a few names, a name that's associated with each one. Like I said, I always mention that one that's more prevalent, that's used most often. So kind of remember at least that one, right?
Can you say what?
Oh, sure. So we have Spiriva is like a anticholinergic. We have Advair, which is like a beta adjunct 2 agonist. It's all in your notes though. There's a slide. Yeah, it's on the slide. So remembering what those are, and sometimes just remembering that you use it for this disease will help you. And if you know what the disease is, then you'll kind of be like, well, it has to be doing this, right? Like if it's a heart thing, it got to be either a contraction or it's, you know, removing the fluid, because I know what the problem is with the heart, you know? And so even if you don't remember exact, and again, that's that adding, right? First, I remember the name, right? If I see that name, I know it's talking about this problem. Then now I add, okay, what does that medication do specifically? Because if I just remember the name and I remember the disease, then I can say, possibly it does this, but then remember the disease has multiple issues. So if I'm just remembering generically, then it's not going to be specific, right? So then you kind of build in order to get more answers correctly. So the problems we're going to have: poor nutrition, right? Because we said while they're breathing, it's hard to eat. Poor activity intolerance, again, hard to do anything if you're losing energy and not breathing properly. Congested airways, risk for falls, and smoking cessation. So we definitely want to do the smoking cessation. We want to look at the intolerance, and we want to look at the nutrition, and we want to look at the oxygenation. Like those are the key things that you usually will see questions about. There's coping and risk for fall. Those are, but good to know stuff. So what are we going to do, right? Intervention, we want to do non-invasive first, right? Oxygen is invasive, but if there's oxygen there, you want to pick it, because you're going to do, like, as soon as you walk in there, you're going to turn the oxygen, then put the head of the bed up, because right as you're going for the remote, they're having the oxygen, right? Like, to me, oxygen is the first thing. And another thing that I notice people think about, and it's because we taught you in the beginning, you assess first. But from the question, you can identify if an assessment was made visually before you get numbers, right? If they tell you the person is breathing at 30 beats per minute, they assess that. Right? If they tell you the person is turning blue, they assess that, right? So you're not going to go pick assessment again. You know what I mean? So you're going to do an action. And usually when it has to do with oxygen, you're going to give, oxygenation, you're going to give oxygen first, right? Then you're going to do the other things to kind of help support what you just did, right? So elevating the bed, making sure they have high calories when they eat, doing the personal breathing, providing the medication, techniques for expelling the mucus, which is like the huff, coughing, repositioning, chest PT. Those are the few things you have to remember. Rest in between any activity to help conserve energy. So those are the key things you want to remember.
So the exception to the non-invasive first is oxygen.
Yeah, that's what I would say. That's what I would say. Like, if you see oxygen there and the person needs oxygen, before you do assessment or anything else, you want to turn on the oxygen.
Because that's like the main thing that's going on, is that they're not getting oxygen.
Exactly. And we already deciphered that by looking at them, right? Like, if they say the patient is anxious and you don't know what's wrong with them, then you're going to assess, because anxious could be, I'm scared because someone's going to kill me. I'm scared because I'm in the hospital, or I can't breathe, because anxiousness is an initial sign of, you know what I mean? Because that's why some of you got it wrong when they said decrease the anxiety, right? Because we know anxiety can cause you to breathe fast, right? But if you don't know, you assess. But if you already can see the problem, you fix it right away, right?
How about if they're having an anxiety attack and you can see that? You still give oxygen? You
still give oxygen, because as you're calming them down, they're taking the oxygen. And also, if it says they have anxiety, but they don't give you numbers, right? They don't tell you that they're at risk for anything, and usually they won't. They'll tell you the person is anxious and their oxygen level is this, and they'll give you an assessment. Then you're going to give the oxygen as you calm them down. Because what you're thinking, the quickest saving grace, right? And that's why we give albuterol before we give corticosteroid, because we want to save them as fast as we can. So by the time you calm them down and do all the other stuff, they're dying. And it took them time to get to that level. It's going to take them time to go back. So if you're going to do the same thing in order to get them back, they're going to die. They're going to die. Okay. All right. So we just did. It doesn't matter. Oxygen is a medication you don't need in order to provide. So assume it's oxygen and EpiPen.
That's why it's in the room.
Yeah. You can give it and then get an order. Oxygen for sure. EpiPen, there's usually an order like overarching order.
Like a
Um,
PRN or something like that?
Yeah, usually. Yeah, yeah. So you think oxygen, you can always give it before, but that's why we start at 2 liters, right? Yeah. And the other thing too, like if it's COPD, you don't want to give them high oxygen. You want to start low and increase. You usually start 2. And also humidification, right? Humidification if you're giving oxygen or high oxygen, right? 2 liters is not too bad, but once you hit 4 liters, you want to give humidification because it's air, it's blowing, it's drying, right? So that's important to know too. All right, so that was COPD. What's the next one?
Wasn't that all of the exam too?
I think so. COPD is the last one, right?
Yeah.
Oh, geez. My pimple hurts. I scratched it. Oh. Okay, so the concept of perfusion. Huh, did I do the concept of oxygenation though? Like, did I do that?
I think you did.
Yeah.
Yeah, I did. Okay, good. Okay, so, oh, yes, I did. Good. My short-term memory, y'all, crap. Oh, we talk about how. So, did you hear about it?
Yeah.
The Sword creamed me yesterday. Everybody creamed me yesterday, not just Sword. He got number 1. We did that. Remember that? Are you smarter than a 5th grader? By the middle, I was just like, God, please don't let me be last. Please don't let me be last. Let me, no, second to last. I was just like, oh, I just can't do well on those. I get so stressed. I can't read fast. I can't.
Oh, yeah,
I just
no. I
can't.
don't think
That's why, like,
I'm
when you
done.
got, I don't do those. What is that thing that Patho when she does Kahoot? Like, I can't. I know the answer, and I'm like, with the. I just can't. I just can't. But I really did know a lot of them though, for real. It was hard. It was hard, y'all. But yeah, I should turn
So
it.
who's first person?
Yeah.
Sword.
Mm.
Yeah, that kid is smart.
Oh, yeah, he's very smart.
I was like, wow, good for you. Yeah, that's so cool. It should have just been $100 gift card, period.
Yeah.
How do they know I like to read, even though I'm smart? Like, I'm just saying, I could be doing other things with my time, you know?
Amazon gift card would be
Right? That would be better. I could do
Yeah.
it. Anything, I could buy anything. Anyway, concept of perfusion. It's my favorite part. I love the heart. Okay, so knowing the path is important because you got to know, like, from what to what to what to where to, like, what's going on, right? So that's a memorization thing. I can't help you there. So you have to remember superior, inferior to right atria to tricuspid to right ventricle to pulmonary artery, thank you, into the lungs, then from the lungs to pulmonary vein, then to the left atria, then through the mitral valve, then to the left ventricles. I always gotta like think,
Yeah,
which
I
side are
was
we talking about?
confused at the left side. When it gets to the left, is it the HM or the, so it's HM first, right?
Yeah,
Then ventricle.
always atrium on top.
Okay.
Always atrium on top. Yeah, A before V. That's a good one. That's a good one.
Oh, I think it's A for B.
Yeah. And then it goes into the aorta through the aortic valve. I mean, aortic arch. Thank you so much. Yeah, so you got to remember that. So those, and the most important, remember, is the ventricles, right? So knowing which valve goes to each ventricle, knowing each valve goes to the heart, that's important too, right? Semilunar goes out and the tricuspid, bicuspid goes down, right? So, and then they have different names, but you got to know which one. Yeah, so those are important to know. Knowing vein to artery, that's bio, good to know, but not something that you'll be tested on per se, right? Cardiac cycle and output, that's important. You need to know cardiac output. That is a heart rate and the heart and the stroke volume, right? Heart rate is nerve and hormones that controls it. It's a beat, right? Stroke volume is blood volume and vascular resistance. Yeah, I think that's hard to remember too. That's like a memorization thing for me, and it's really hard. Like, you got to kind of repeat it. It's one of those things that I would like write down right away so I don't forget it. But it's hard for me to kind of remember. So I read it. So, but you have to know it. It's important. Then we have the ejection fraction, which is the amount of blood pumped out of the ventricles over the amount of blood in the ventricles. And that just tells us that there's a little bit of fluid that's left after the contraction happens, right? This is like the structure. This is the biology part that is good, it is important for you to know. Factors that affect cardiac output, heart rate, preload, afterload. You got to remember preload and afterload. Preload is the amount of fluid that goes to the heart, like the whole amount, right? And afterload is the amount of pressure I have to apply in order to get that fluid out, right? So those are the two that are most important. Obviously, heart rate is good to know, and contractility is good to know as well, because medication will affect each one of those, but you need to know that concept. The next thing is the conduction. That was the plumbing. So the conduction, you have to know the SA node is the pacemaker. It's at the top, so it regulates the atrias, which are the P's. Then you have the next one is the AV node. The AV node regulates the ventricles because it's above the ventricles. And then it's the bundle of his, and then the bundle of branches, and then the Purkinje's fibers, right? It's good to know those, but the most important ones to know is the SA and the AV, right? Knowing the others are just below is the most important part to really think about. Knowing, like, you know, the heartbeat, lub dub, like what closes, what opens, that's good to know, but I have seen questions about that, even if it's not on your exam, but it could possibly be on the NCLEX. So keep that in mind as you kind of study this thing. See, the pacemaker could be SA or AV, because you can have A pace or V pace. A pace means it's pacing the atria, and the thing that paces the atria is the SA node, right? Because we said the SA node is on top of the atria. So if it's A pace, it's replacing the SA node.
And we can lose the SA pacemaker.
You
right?
can, and then you still survive, because the AV node paces the ventricles. So then the pacemaker could be in the place of the SA node, or it could be in the place of the AV node.
Do they usually have both of them, or usually just one?
Both. They can have both. It depends on which one's broken, right? So we have the heart. I don't know if I should do this. Does that look like a heart? Not really.
Like a
Looks
rock.
like a potato.
Okay, let's make it look more like a heart. How about like this?
That's how my hearts look like. This is like potatoes.
There we go. He's like, the septum. I think this should be bigger. Y'all understand what I'm trying to say? Look, this is smaller. This is something like that. Okay, it looks like a shield now. So we have the SA node, which is here, that signals and contracts this. And then we have the AV node that is here that signals and contracts that. So if this is broken, they're going to replace this with a pacemaker, but they can also put the pacemaker here too. See it?
Sorry, can you see it?
Oh, yeah, no, I was asking us because there's no test.
There was okay.
Which one?
If the
Yeah.
primary pacemaker is broken, then what does it affect?
The SA.
SA, because that's the primary. The SA is the first one that signals everything. Yeah. So and then it'll affect the SA node. If the SA node is broken, then we're not gonna beat at 60 to 100 anymore. We're gonna have to jump down to 60 to 40 to 60, right? Yeah. So that's that. Okay. So the next thing to know, the whole idea of calcium channel blocker, potassium, all that, good to know, right? I don't think you'll ever see that in a question, like specific details on it, but the concept of understanding this is why those medications work. This is what they do. They replace this natural thing. Is just the thing that you need to remember.
When it comes to the EKGs, don't we need to know it then?
Nope. You just need to know what the medication is doing. So if you need to know it to the extent that it tells you that this is exactly what the body is doing, right? And even if like, let's say if you take a atenolol, or whatever, or a calcium channel blocker or ACE inhibitor, the question is not going to be is the potassium going in or out of the cell? Is the you know what I mean? If that's not what it's going to be, it's going to be what's the end result, either contractility or it's going to affect afterload, preload, the muscles, like those medication affect, specific things. They don't really ask you about the influx in that. That's a biology thing, but it's good to know so you can understand, that's where they get that whole calcium channel blocker business. Or, that's why potassium, if I get too much of it, it'll affect my heart, right? Like hypokalemia, it'll affect, hypo and hyper will affect. So just, it helps you understand that concept.
Hyper is worse, right?
Hypo is actually worse.
I thought hyper is worse for potassium because it can stop the heart.
So the reason why hypo is I think they're both bad. I don't think one is worse than the other, because hyper, you can give Kexalate to remove it, right? And then hypo, you can administer potassium. But either one, you have to monitor. They have to be on a heart monitor. So either one, hyper is worse.
Like that's why they give potassium put on the heart and OR to stop the heart for heart surgery. And then that's why she's always like explains like potassium because like a decay, like potassium's up because it could cause like cardiac arrest.
Right. Well, I can't really say whether if she says it, then I'll defer to her then if that's the case. But I just know, where was I reading? What did hypo do? Hypo did something. Anyway, hyper is bad, hypo is bad. Potassium shifts are just bad. We don't want that. Let's see. Okay, so now moving on to what does P stand for? What does QRS stand for? So the most important one is know what P stands for and QRS and T. And T is not even as big. The big one is the P, which stands for what?
Atrial contraction.
Contraction, which is the same thing as?
Depolarization.
Right, atrial depolarization, right? And then QRS is the same thing as?
Ventricular contraction.
Or ventricular depolarization. And the T stands for? Repolarization of the ventricles. Yep, you definitely need to know that. Okay. Again, we mentioned like the measurements, good to know, but if you can visualize and just like when you took the test, like who was measuring? Nobody. Like, right? It's like you just kind of remember what it looked like, right? You won't have to measure up until you get to the floor if you're actually on the telemetry unit.
Does it usually do that though? Doesn't the machine do that though?
It does, but sometimes machines can be off. Yeah. So the measurements, the rule of 300, the rule of 1500.
I gave that one up.
Yeah, it's like, if ever you have to, then you use it, but otherwise, like honestly, just looking at it to me is the best way. I save myself time from memorizing anything. So risk factors, we have hypertension, hyperlipidemia, obesity, diabetes, stress, alcohol intake. Those are the biggest risk factors and lifestyle choices too that affects our heart. We talked about fatty foods and atherosclerosis and how they form plaque and how the plaque can crack and how it can cause embolism, all of that. So that's a bad thing. So that's why we're definitely monitoring our cholesterol and stuff like that. Okay, so that's done. What's the next one after that? Is number 1, right? Oopsies. So we have the notion of P, QRS, T. They look a certain way. Okay, so let me think. So when we're looking at a normal EKG, we know that the rhythm is 60 to 100, right? Our biggest thing is, where are the R's? Are there P's? And is the QRS wide? Like that is the best way I can help you understand how to identify when there's a problem. Because like we said, it's not always going to be crisp, beautiful. And then, sometimes one is a little higher than the other. So the bigger thing to focus on is what is the distance? Are they equal, right? If they're not, that means they're irregular. And if it's irregular, that means there might be a possible problem, right? An irregular heart rhythm means there's a lub dub dub lub dub 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 lub, whatever. They're doing something crazy. So we're looking at the R intervals. We're looking at the existence of a P and a QRS. We're looking at the width of the QRS, right? So if you don't see a P, that's a problem. If you see multiple P's, that's a problem. If you see a wide QRS, that's a problem. Usually or if you don't see a cue, a smoothly looking, and when I say smoothly, like from this one to this one to this one to this one, they look exactly the same. If they look exactly the same, it's normal. You see what I'm saying? But if you have one that looks like this and then one is wide, there's a problem. So like identify them that way, okay? Because like I said, they're not always going to look the same. Let's see what else. Determining the rate. We talked about that. The rule of 300, rule of 15. Oh yeah, because we covered it. But you know what I saw though? There's a lot of math.
On what?
Yeah, on the final. And the final, there's like, when I say math, like there are 3 parts. Like one question has 3 parts, which is to me horrible.
That's amazing.
I can't, because that's part of what you're expected to do. But I'm letting you know now, because you have to be very careful in that first answer, because if you get the first one wrong, then it's all going to be wrong. Dosage and count. No, EKGs, they're relatively simple. Like I said, just visualize and know. But if you're not good on your math, please practice the math. Go to that tutoring lady, young lady.
Are you saying this more because it's like main parts or like?
There are a few. I'm gonna send you the breakdown. But even there, if there were 3, the 3 have 3. So you know what I mean? There's like 9 questions. So, there's like 1 or 2 simple ones, but a lot of them are multiple parts. So please get yeah, I really can't help you there, but I can tell you to be careful. Yeah. So
Wait, did you use, but can you tell us like is that 1 point for the 3?
no,
3 points.
it's all no. Yes, it's 1 point for the 3. It is 1 point for the 3. Yes,
Okay,
yes,
that's
yes.
fine.
And I can go in and yeah, you could. That's true. But the thing is, if you miss the first one, you miss all 3 of them. You see what I'm saying? They're all connected. So you can.
What they ask is, okay, one question is 3 answers, right?
Mhm.
If you miss one,
You possibly can miss the second.
but is the whole question, the 3 included, is it 1 point or is it 3 points?
It's 3 points.
Oh, wow, never mind.
It's 3 points. So it's a good thing that it's 3 points, because if by chance you're like, yeah, that didn't make sense, I'm just gonna put 3, from your calculation, then you can possibly get it right. But if you're using the calculation that you got wrong in the first one, you'll get all of them right.
I just
Wrong.
thought all of them would be considered 1 point. That was actually.
And then I just divided, and it would be like 0.33 if you missed
Yeah.
one.
Yeah. So just make sure you're careful with your questions, your math. Let's see. Okay, so we talked about PAC, right? The biggest thing with PAC is rhythm, R, and then R, right? R, like the others are distant, a good distance, and then the one is like really close to it's premature, right? That's how we know.
Because the H is going to contract earlier. Right?
Earlier, that's right.
But you still see the P though, right?
You see, yeah. You definitely see a P, you see a Q or S, because that's not the problem. The problem is not the P is broken, it's just it happens sooner than it should. The rhythm happens sooner. It's a good rhythm, it's a sinus rhythm, but it just happens sooner. That's a PAC. Okay, so what are we going to do for it? So the most important, just like the last exam, we need to know what it looks like, and we need to know what's the treatment for it. We don't worry about the cause or whatever like that. We just want to know what it looks like, and they'll ask you like, what do you do for a PAC, right? So in this case, if it was a PAC, if there's a run, we give amiodarone. And then we notice like the stable, non-stable as well, right? So this one has no stable, unstable. So it's either you're giving arrhythmic medication, so beta blockers, calcium channel blockers, and things like that. Or if there's a few of them, you're going to give amiodarone.
No, the run you give amiodarone.
The run. A few of them is what I mean. The few.
But if there's like 1 or 2, right? You just monitor, right?
Yes.
You don't do nothing. Right?
You don't do anything. If there's just 1 or 2 separate from each other, you don't do anything. But if a run is there close to each other.
Yeah.
So then when would you do the beta blocker, calcium channel blocker?
So it says treat the underlying cause, give beta blocker. So I guess if it happens too frequently. So if it just happened right now, and then months down the line, it happens again, then it's not a problem. I'm not going to do anything. But if in a month I have a little jump in a feeling, and it happens twice a week, right?
That would be considered unstable then, right?
It's unstable is usually only when you have signs, like when I have a
Okay,
headache and
symptoms, yeah.
symptoms. Exactly. I keep saying signs, but yeah, symptoms. But you know, there are people who have like, you know, like for me, when I mentioned my Wolf Parkinson White, this is what I had. I didn't have a headache. I didn't have anything. But then that day when I did an all-nighter, like I felt lightheaded. I was like, oh my gosh, something's wrong with me. That's signs and symptoms, right? But then the other times, I just didn't do anything. I did the Valsalva maneuver and kept it moving, just because I wanted to stop.
Valsalva is just for SVT, right?
Hmm?
Valsalva maneuver.
Valsalva,
Valsalva.
yeah, it's for SVT. It's for Wolf Parkinson White that you don't have to think about. But the point is, it jumpstarts the heart. It stops it and restarts it, without invasive procedure type stuff, medication and yeah. Okay, so the next one we're looking at is we didn't see us Brady and I jumped. Y'all didn't say anything. I jumped.
Those are
Go ahead, tell me.
pretty much easy, though.
Yeah. Go ahead.
I heard classmates talking like, okay, well, you know, if they're in tachy, what med, like, can we classify it like that? Like tachy means what, give what med? And then,
Tachy is like where you want to, so with bradycardia, right? You want something that's going to jump and make it go closer to normal. So
Mhm.
you're going to give atropine,
Yeah.
okay,
right?
okay.
And then for tachycardia, if it's going like super fast, don't you just monitor?
You just monitor it.
until it's unstable, right?
Yeah. So when you think about it, right? Brady, it stretches so much that you might not get another beat.
Okay.
You know, that like, when you think about it, that's a more of emergency than if it's working too hard,
Okay.
because it's the tachy is kind of like high blood pressure. People live with high blood pressure all the time. You see what I'm saying? So, but Brady, if it slows down, eventually, if it'll come to a stop. So we got to do something about Brady more so than we do tachy.
Okay.
But yeah, we watch him with tachy, and with Brady, what do we do again?
Atropine.
Atropine. That's right. Okay. You guys got that one. Yo, on the exam, I was like 100%. Everybody got this. I was like, okay. Y'all made me so proud.
I was like nervous for that though, but once I started doing it, like it was like really good.
Yeah, good. All right, so we talked about PAC. Let's see. Then we have atrial flutter versus atrial fibrillation, right? So atrial flutter, if it's stable, we give anticoagulants. If it's unstable, we give amiodarone.
See, that was one of the questions that I got wrong on the exam. But I thought if it's unstable for atrial flutter, the first thing you do is cardioversion.
Me too.
Yeah.
That's fibrillation. Flutter is smooth and still under control. Look at your slide. Yeah, so the slide says unstable cardioversion. For atrial fibrillation, you're gonna cardiovert it.
I mean, I'll look at it.
Atrial fibrillation. Look at the slide. Atrial fibrillation. No, that's VFib.
That's
And
only one.
I even was like confused myself actually when one of the students asked a question. I was like, oh, that's defibrillation, and then I had to go back to the slide and look real quick and like, oh no, never mind, that's
Okay.
VTAC.
Wait, what did you just say that the,
So atrial fibrillation. Look at atrial fibrillation.
said what?
It says when it's unstable, you cardiovert.
But didn't you just say atrial flutter?
No, atrial flutter, you do what is it called? Amiodarone if it's
But
unstable.
On here, it says unstable cardioversion.
For what?
And I got that wrong. Here.
Me too.
What does it say?
And I was
Unstable.
100% confident on it.
Huh.
Me too. And so
See,
that's the one.
because I knew it.
Me too. I
knew
talked
it.
to you in the hallway,
I knew
remember?
it.
So why does ours say different things? Look at my flutter.
I wonder if maybe you changed it after it was already posted.
Unstable cardioversion.
Yeah,
Because I write on this during class.
Yeah,
So if
yeah.
it was
Yeah.
different, I would have crossed it.
No, sure. I mean, obviously that's
That's one more point. Okay, please.
Give it back.
Ah, okay, I gotta go
remember
look back.
cardioversion was the only.
So
any other wasn't on there.
look for
know.
flutter, look
It's
for
right here.
fibrillation.
Because I memorized them the same.
So
as the
it's
same
also
treatment.
cardioversion. Oh, okay, all right. So this is
Sweet.
how. So this is actually was not me. This was done before.
To give me that point.
Yeah,
At
sure,
one
sure,
point.
sure.
That means
I
I'll
don't
pass my
mind
test.
because apparently this is one slide, and this is a different slide.
Both of them say cardio first.
So my slide, as
Yeah, yeah.
she sees, doesn't say cardioversion
Yeah, no, hers does say
For
amiodarone
flutter or AFib?
for a
for
flutter.
a flutter.
But I'm assuming it was changed after.
It
we
must have
already
been,
posted.
yeah. Like the thing is, there are different slides that the professors go by. You saw that under files. There's one, I might have deleted them, but there's like a Krista one, there's a 2021. So people come in and they kind of revamp and read whatever.
Krista
So,
who? Right?
I don't know. It just says Krista. Yeah, so I'll check. No, go ahead and email
So
me.
then
I'll
maybe
fix
we
it.
need to get one.
Yeah, I can definitely do that because it's
What
not
about
fair.
me? For me, just us though.
Yeah, no, no, that have to be fair. Go ahead.
So you want us to put amiodarone?
I want you to put fibrillation.
Over the treatment for AFib and flutter.
So okay, so for a flutter, so what I'll do, I'm gonna go and I'm gonna delete the slide that's up there. I'm gonna put this slide. So that way you have it as well. So for atrial flutter, you know what? I'm not gonna do it now. Let me go read the book and be sure, okay? Because I don't want to say it from my thoughts because I'm looking at here. There were two different slides created by different people. I'm reading what other people wrote, not what I myself investigated. Oh, sure. I'm going to change it and then I'll announce that I change it. I'll email you guys.
So we will get it though, regardless.
Regardless, yes, because I visually see that. Praise God. Praise God. All right. So let's go back. And what are we up to now? So we did the flutter. Okay, so flutter. And so then the fibrillation, then we have, so the most important thing too is we know we have anticoagulation in either one, right? That's for sure. And I'm gonna make sure, yeah, because it's not pumping it out properly, so it's sitting there. So I'm gonna go make sure if we do cardioversion for both. We know for sure we do cardioversion for the fibrillation. So I'm gonna go make sure if we do it for the flutter as well, okay?
But for the fibrillation though, it's because that could be controlled or stable and unstable, right?
Mhm.
So for unstable, that's what you do.
We also have stable and unstable for flutter as well.
Yeah.
Yeah.
Okay.
So let me go read it and to be sure. I don't want to just say from what my thoughts are. Okay. So that was the atrial fibrillation. That's the last one. So remember the cardioversion for that one and the anticoagulation for that one. Those to me are the most important thing and identifying it visually. Okay. Anything else you want to add after? You want to make sure you know those and expand. Remember, guys, remember, once you've got it, you want to expand, right? Because you're not studying only for this exam. You're studying for the NCLEX later, and it's going to be crazy horrible for you when you get there. Like I did a review for OB for our exiting class. When I tell you they were on point, like they knew their stuff. And I want you to be that confident in what you know and remembering it as well, right? So doing that as a practice. Okay, let's move on. The next one is the second one, right? Mhm. So hold on, let me look. Let me get to it.
I am so thrilled. you guys. We're in the hallway.
Yeah, you did say it.
Yeah.
And once other student mentioned it to me as well. But then I saw that and I was like, nope, sorry. So she got it wrong. But that means a few people are going to increase. They're going to see an increase in their grade, which is awesome. I don't mind that at all. I love it. Let's see. Okay, we're going back to open and here. And then we're going to do the second part. 2. Okay, so for district number 2, we're looking at the ventricles. We know ventricles are worse, not great. We're looking at premature ventricular contractions. So the difference with that is it'll start sooner, but the problem is we're not going to see a normal PQRS. We're going to see a weird QRS.
When that goes down.
The point is it's wide. It's like, it's like this big. And once we see that, that's how we know it's a ventricle something, right? We know it's a ventricular something because the QRS is wider. And when you look at all the definitions, even in numbers, you'll see the numbers are bigger than 0.12, right? So that's how we know. So you're going to see a normal PQ, and you're right though, in that is deeper, the other ones even. The normal ones look like the QRS is like further down and then it comes up. But I don't want you to, just in case it doesn't look like that, what every single one is going to look like is you're going to have a wider QRS.
So
Okay.
that's what's gonna differentiate the wide.
The wide QRS is going to tell us that it's a ventricular problem, and it's going to happen sooner than it should, right? So it's going to be like a PQRS, and it's going to be like whoosh, 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 and then the PQRS, and then whoosh, whoosh. Like it's going to be like this huge difference, right? So that's how we're going to be able to tell that it's a premature ventricular contraction. For the treatment, what we're doing, we are monitoring the patient. That's key, right? We're not doing too much for them until we have what? More than one. If we have more than one, which is bigeminy, trigeminy, we're afraid that it's going to end up becoming just VTAC, exactly, right? So that's our worry. So, but if they say a person has, if they don't say multiple PVCs, and they say stable, or I don't know what other words they could use, but the point is you don't want to bother a PVC because it's not a problem. All right. And it becomes a problem only when there's a lot of them close together, not one here and one here and one there, but together. Okay. So we're going to treat the underlying cause, we're going to give arrhythmic medication, and we're going to monitor the patient. Okay. So VTAC, what does it look like? Right? Up and down hill, like mountains, mountain peaks. That's what I call them. And they're wide. There's no P's. Okay. Ventricular tachycardia. We're looking at the wide, again, QRS. We're looking whether it's pulse or no pulse, right? Stable versus unstable. And either way, the treatment is we're going to do cardioversion if we have a pulse, defibrillation if there's no pulse.
Because that would be VFib now.
Yeah. Well, it's not VFib, it's VTAC. But if it's unstable and the person is like, possibly there's not going to be any pulse. It's because there's no pulse. If there's no pulse, that's when we do defibrillation, right? If there is a pulse, that's when we do cardioversion. Because cardioversion means we know, we're planning, we're monitoring where it lands, all of that. Whereas defibrillation means, I don't know what's happening right now. I just need to find out so that if there's a signal somewhere, that I could just get them out of this, right? So unstable, we want to do might even do what is it, CPR. Like you want to, and these, that's another thing too I've noticed, like you want to do CPR before you defibrillate, right? That's like basic what is it called, life support stuff, right? You see the person, you say go get the AED, and you start CPR. So you do CPR first. Okay, moving on. We're looking at now fibrillation, which is like little squiggly lines. It could be tiny little squiggly lines, or it could be a little bigger squiggly lines, but there's no evenness to it. There's no pattern to it. So you can definitely tell that this is a bad situation. Okay. The more steep, the better it is. The less steep, the worse it is.
Wait, sorry, the more steep the worse it is?
Yeah.
Like
No, the
fine.
more steep, the better,
More steep.
because you can have
Oh,
impulses.
fine, of course, okay.
Yeah.
Fine is the one that's like
Small, tiny little, almost
Okay.
gone.
Oh, I see.
About to be a
Gotcha.
line.
Okay.
So what are we going to do? We're going to, if there's no pulse, we're starting CPR, right? Definitely for the VFib, you're doing CPR for this patient, right? And you're and defibrillation, right? Either one. There's no cardioversion for this one, right? It's just defibrillation. Then we talked about asystole, which is they could be like little P's, but it's over. Like they can't do anything or nothing at all. There was someone who confused the fine VFib with asystole. They don't look the same, right? So remember that. So it's non-shockable. You can't do anything for them.
Well, you still give like
Epinephrine, yeah.
Big gun.
And the CPR, because the thing is, we can't, as nurses, say they're dead until the doctor comes. So we're doing something up until the time.
Until
Right.
the second they
I thought about it too.
So the bullet penetration flatlines,
Uh-huh.
there's no like.
You can't shock them.
Yeah, there's no,
Electric
that's
TV
done.
shows, lights, and-
those, I know they did, they sure did. TV shows, it's like a flatline, shock 'em.
Shocking the dead body for like an hour.
But honestly though, you've seen that sometimes, like after the CPR and like once they see the line, they'll do it 1 or 2 times, but then that's
So
it. They're like,
good then. Where they like,
when they actually, no, they do that in hopes that they'll find something. Like the same way that they give the epinephrine and the CPR, even though you like, you gotta do something, you know what I mean?
yeah,
I feel that that's why they do that. But if it doesn't have something to jump on, that electricity doesn't have anything to catch on, it's not going to do anything. And that's why even after they shock and clear, the person doesn't come back as long as they become flatline. Like you've hardly, this is what you've hardly ever seen. You've hardly ever seen flatline for minutes on end,
yeah.
and then they come back. You've hardly ever seen that on
See, and
TV.
I think like in the TV shows, what's happening is that they're doing every measure. So honestly, they're doing CPR
Yeah.
first, and then they give epinephrine. And the third thing, it's
Yeah.
not the first thing you do, but you still shock.
Yeah, this is the last resort because you want to make sure they know you did everything you can. You know, and they always say, make sure you do everything you can, doc. You know, like they always say that, do everything you can, doc. It's usually the husband talking about the wife that's about to die. But I'm saying, anyway, I just watch too much TV, sorry. Well, I don't watch TV, movies.
Streaming.
Yeah. Okay. Pace rhythm now. Okay, so we just talked about it with, it could be atrial pace, it could be ventricular pace. And usually I mentioned, you'll see a spike that tells us it sent the signal, it captured it, we see motion. But it doesn't always have to be, right? And the way you'll know is, actually, you know what? To be honest, I'm not even sure. How do you tell?
If it didn't work.
The only way you could know without the spike is if you see a little P, then nothing, then you see a little P with something. Then that tells me they had to have something there to send that little P, but then they didn't have enough in it. I don't know, whatever,
So
right?
when you see it on the EKG and they have a pacemaker, you're not gonna see that spike, that little.
You
line?
will, you can. But there are times where it might not be there. I don't know why. I'm not a
But it's still
cardiologist,
working?
but it's still working. Yeah,
Alright.
yeah. I actually removed one of those questions because I didn't like that because I'm not a cardiologist, so I don't know the reason behind that. I prefer to tell you that that's a possibility, but not test you on something that like how, you know what I mean? Unless you go and become a telemetry nurse and then they explain to you what it is, what it looks like when that's not really what I need you to understand is that pace means electrical shock is delivered. The heart picks it up and it does an action, or it delivers it, the heart does not pick it up, there's no action, but there's a spike there that shows you something was delivered. I prefer you understand that concept, and whatever after you'll learn when you get there.
So on the final, you won't give us an EKG with the pacemaker.
With the spike missing, no.
Without spike, or you won't
No.
tell us.
You want the whole exam?
No, I'm just saying that because I don't think it's fair
Yeah.
to do that to you, because I don't even know like the actual reason behind why it wouldn't be there, because that's how I learned it. So when I saw a question without it, I was like, what the heck is that? Like, how would I have known, And so as a person who went to school who didn't learn it that way, I would not do that to you. Okay, so but obviously there are new things out here. So I'm not in the field in acute, so I'm not sure. Anyway, pace rhythm, you're gonna see the spike. So we said A or V or just one. A can just go through the whole thing because A is SA, so it carries it through. And V is, if there's V, then you assume that, see, that's the other thing I'm not sure, like if it goes all the way through, but just know that if it's V, it's right in front of the QRS. If it's A, it's right in front of the atria or the P. Yeah, thank you, the P. So that's all you need to know, okay? And again, like I said, you'll see the spike, so you don't even need to know, well, I guess if you need to know AV pace or A pace, V pace, you'll know which one, okay? So the pacemaker can be a defibrillator, and it could be a, what is it called? Cardioverter, what's the other one? Hold on, I forget, that's Well, let me just see ICD. Hold on. Okay, so ICD as in one can detect when there's a problem and the other one can fix the problem, right? So that's one thing to remember. Oh, that's just nice to know stuff. It's just I like to dwell on it. It's like it'll tell you when the heart is not pumping properly, when you need.
It's like a diagnostic test.
It's, hold on, let me go back to where we talked about it to be sure. I don't want to just speak from the corner of my mouth, as they say. I forget the difference. Hold on. V. Hold on, where is it in the notes? So it is a, hold on, let me see, where did it go? It's an implantable cardioverter defibrillator. So it does both. It measures to see when there's a pulse or not, so it can cardiovert. So if there's a pulse, it'll send a shock. And it could also defibrillate when there is no pulse, but it senses there's a signal, right? Because the which is so weird to me, but anyway, so the pulse or no pulse is what decides which one is going to be used. If there's no pulse, it's going to send off the defibrillation part. If there's a pulse, it's going to send off the cardioversion part. That's all. Okay, and that's that. So what's the other one?
Hypertension.
Hypertension. Do we need a break?
Wait, how long are we going for?
I mean, I could finish, or we could just, what is this? It's 12:20.
2 more hypertension.
So you wanna, what's next time? You wanna finish?
How long do you think it takes? Some of the topics are quick.
I'd finish, to be honest, and then next week you just focus on doing it on your own. So let me just really go really quickly. Okay, so with hypertension, knowing your numbers, what is high, what is not, right, is important to know. Let's see what else. Knowing that it's what is the thing called? Silent killer. So you can't really tell you have signs until the person is having end stage or organ damage. That's important to know. Knowing the different factors, the risk factors that might cause it. So that means I'm going to fix those problems in order to prevent it as well. Knowing about, the medication that you have to take, the different medications, like, if I say, exactly, loops, or if I mention diuretics, like, the calcium channel, like, that I'm talking about, hypertension. Knowing the different things I'm going to do, other than give medication, reduce stress, tell them stop smoking, eat better, exercise. And that's really the key thing to remember, right? Identifying that is high, knowing what possibly caused it, and understanding that they won't know that it is there. So you have to teach them the different problems that they'll have and how you can reverse it, because it's the only disease that can disappear. That in diabetes with different health whatevers. Yeah, so that's hypertension. To be honest, like that, honestly, like If you understand that knowledge and that concept, then you can possibly answer any other questions. Let me see if there's anything specific, more specific than that.
But I would like to ask you the
Uh-huh.
organs.
Okay, so organ damage. Okay, so the organs we're talking about are the kidney,
Mhm.
the eyes,
And the nerve, right?
and the nerves. Those are the
I'm
most
kinda
important.
confused, though. Isn't
So-
like hypertension, like it'll never go away?
It will. It will. Because hypertension is just you pushing really hard on the vessels. So if I can do something that either can help decrease the amount of fluid that's being pushed through, because the heart, if it's a heart failure issue, then no, because I can't change the heart. I can't,
Like, you
like,
can't.
but you can. Hypertension can go away. If it's obesity that's causing it, if you reduce the weight, it will go away. If it's diabetes that's causing it, if you get rid of diabetes, which you can, it will go away.
Diabetes, I know you can, but I thought hypertension, you could just manage it. You can't.
No, it can go away.
Like,
How do we know it's gone?
The blood pressure.
The blood pressure numbers are down, right? If we can maintain it for an amount of time, what are we going to do for them? Remove them from the medication. They're cured. Now, if they already have end stage failure of something, that we can't fix because we can't undo the damage of the artery. If they're already blind, if they're already on dialysis, right? Those we can't fix. That's the part that's not fixable. But if we can find it before those things happen and we tell them, listen, like you need to check yourself, right? And they fix those things, they won't get the organ damage and they're good.
I'm sorry, so it's kidneys, eyes, and nerves?
Those are the most important ones to remember. But you understand that it says end organ damage. So
That's it.
any organ could be affected. But knowing that the glomerulus, these are tiny vessels. Remember I said macro and micro for diabetes is very similar with hypertension, right? So it's going to affect any organ. So if it mentions liver issue, but it talked about organ, we're going to pick that because that's an organ. You know what I mean? But mostly the eyes, the kidney, and the motor, meaning my feet not beating, if I don't feel my legs, that kind of thing. All right. Yeah. So that's any other questions? Okay. So we're done with hypertension. And the last one is P. Last one, PVD. Here we go. Okay, so again, PVD it's easy, but it's hard only because of the similarities between them. So we focus on the things that are different, okay?
like the area being affected.
Right. Wait, like what?
The area being affected.
The air, not exactly, because they both could affect extremities, right? They're PVD. It's how they affect it, right? So first of all, they're different because one is vein, one is artery, right? That's different. Secondly, they're different because of what happens. The artery one is because of the atherosclerosis, the plaque, and the vein one is because of the valves. That makes them different. Then, since we know it's an artery and vein, then we know the functions of those two things are also different. Arteries take blood away, and veins take blood too. So if it's an away issue, away from the heart to the legs, I can't get the oxygenated, nutrient-filled blood to my toes.
But don't you have edema in the upper extremities?
So you will have edema mostly in the lower extremities
I got that
because,
from CVI.
Oh, I have a question.
tell me.
Okay, on the exam,
Mhm.
I don't remember what all the answers were, but there was a question about what the person with PAD should be instructed
Mhm.
to do.
Mhm.
And one of the answers was that they should feel the bath water to
Yeah,
see if
yeah.
it's hot or not.
Mhm.
But you shouldn't, because you might not be able to feel the temperature because of its.
No. You have to feel it first because they can't feel it with their feet. So you would feel it with your elbow. You would
But
take,
that wasn't
no, but the point is you have to measure the heat of the water before they go and take a bath, because they won't know, like when they,
But it says they put in their hand.
right.
That was the answer.
So
You
the
can't put it in your hand, so that's not what your answer.
That wasn't that was wrong.
It
I
was
chose that
wrong?
and it was wrong.
Okay.
So usually you have to put your elbow, the less sensitive, I don't remember anymore. I'd have to look. But-
I think what I put was wrong, and I was like, oh.
But it's like, don't wear compression socks. Like, it was a multiple choice, select all that apply.
Yeah.
I got that one right though.
The other one was compression, was, can you use compression stockings for PAD?
You don't.
No.
But you instruct them to not wear them.
Or wear like.
So maybe that was the thing, not, or do it. Like that was the, yeah, maybe it was the opposite thing and then you missed.
I knew that you can't.
Right, because you don't check with the extremities because they won't feel, but you check it with the elbow where,
I
yeah.
think the question was, what do you instruct them? And the answer was to not use compression socks.
Yeah, I'm not sure.
And I think that
We're gonna look on Monday. We're gonna look on Monday. So Monday, I'm sorry we weren't able to check it before, but we'll check it Monday. Yeah, so those are the things we're looking at. And then we're looking at keywords, right? We're looking at intermittent claudication, that's for PAD, right? So those are the key things we're looking at to remember first. Let's see, anything else? So we have pain with the calf and we have the decreased pulses. We have,
Decreased pulses in PAD, right?
it is in PAD because it's not getting to the extremity to feel the pulse, because the pulse is felt in the arteries,
Yeah.
right? Yeah, so that's the PAD. Toes and feet, ulcers, numbness, so that's PAD. PVD is the edema, but edema is more dependent because the fluid is sitting there, right?
And that's what I meant, like the areas being affected, because like with PVD, it's all gonna be lower.
Mhm.
So it's just like with the venous stasis ulcers,
Yeah.
you're gonna know that it's gonna be not dry
Yeah.
because there's blood there.
Mhm.
But that's all with the lower extremities because of C guys. So I kind of differentiate, like when I was in the exam, I differentiate PAD is all upper,
Mhm.
C guys all lower, basically. That's how I remembered it.
That's okay, and that's fine if you remember it that way. But the only thing is, in PAD, intermittent claudication is your feet and your legs, and that's lower, right? Also, ulcers is usually in the feet, that's lower, right? So, but if that helps you, if it helps you to say lower and then just add intermittent claudication, restless leg syndrome, then all you're doing is just adding to that information and you're making the exceptions, and that's fine. Yeah, so with PVD, it's mostly the swelling, discoloration, and that's really it, like, honestly. The risk factors also we need to know. Yeah, oh, yes, that's the key. That, yeah, how did I forget that?
Venus, you put the legs up.
Up, yep.
And then arterial.
You put it down, that's right. And which is nice. I actually like the way you did that, because Venus is a V and the legs are up.
Yeah.
And then
Oh, sure.
utter is down. That's so cool. I never thought of that. Oh, see,
I would like
it's good when I tutor.
credit.
Yeah.
This is what Zach
Oh,
said. Veins elevate legs, and this one.
Oh, she did too. I don't know who did it first. I
It was
don't know
on
if
that
I.
video.
It was from Simple Nursing.
Oh, okay. Gotcha.
He said it like 3 times in the video. He said, the biggest thing I can share with you is this.
That's cool. Awesome. So for risk factors, the smoking is an issue for arterial, and diabetes is a big one. Hyperlipidemia, hypertension. Okay, so the smoking, the diabetes, and the hyperlipidemia. For actually, yeah, hypertension. So for venous stasis, it's obesity, pregnancy, inactivity. Smoking is in both. The diagnostics, it's good to know. You can go over that so you can recognize when it's mentioned. For treatment, we're since they're different situations, we're treating them differently. arterial issues, we're trying to make sure the blood gets down. So anything that's going to help the blood circulate better, like aspirin, Plavix, things like that.
And I think one of your exam questions too, and I think it was kind of like trying to trick us, was like to eliminate like movement or ambulation.
Yeah,
is
yeah,
not
which you don't
correct,
want to do
because
that.
you still want to do it even though they have pain. then stop.
Exactly. Yeah, you never want to just stop movement at all. Yeah, definitely. Good job.
You try to get me though.
Listen.
You did.
So we got me.
And for CVI, we want to eliminate the symptoms, promote circulation. So we're trying to fix what's the problem with the venous. Since it won't close properly, we'll put the stockings on. We want to put the compression so that it can close properly, right? So those are the most important things. And that's it. The end. The
Thank you,
end.
and thanks so much for doing it today.
No
everyone.
problem. No problem.